Good afternoon, everyone. My name is Precious Dimba. I'm a UKZN Psychiatry Reg, currently in her third year. So I'll be presenting my research findings today. The study title was Food Insecurity in Women with Mental Illnesses Attending a Specialized Psychiatric Hospital in KwaZulu-Natal. Those are my co-authors, with Dr. Mashapu as my supervisor, and we're all affiliated with the Department of Psychiatry at the University of KZN. All right, so in the literature, there's quite a few definitions of what food security is, but one of the definitions is that it's a situation where people have access to enough food for an active, healthy lifestyle. Its counterpart, food insecurity, is a global problem that saw a rise with the COVID-19 pandemic. However, pre-pandemic rates were still high. There were some studies that showed that in Africa there were more than 676 million people who were reporting moderate to severe food insecurity, and also some results that showed that 1 in 4 people who do not have enough food are actually located in sub-Saharan Africa. In South Africa, where I'm based, the levels of household insecurity range between 26 and 29% in the general population. And in the last part about water insecurity is not part of my study, but I felt that since it's receiving quite a lot of attention globally, and especially in South Africa right now, it warrants some mention. So water insecurity being on the rise, initially a problem that was thought to be in rural areas, but now is being seen in urban areas as well. All right, so when we look at subpopulations that are considered more vulnerable to food insecurity, persons living with mental illnesses and women are particularly vulnerable. So when we look at persons living with mental illnesses, there was a meta-analysis which consisted of 16 studies from predominantly high-income countries that reported a prevalence of food insecurity in persons living with severe mental illnesses to be 41%. In South Africa, the South African Stress and Health Study showed a significant association between food insecurity and having a 12-month and lifetime diagnosis of a DSM-4 anxiety disorder. So there are multiple reasons in the literature as to why persons living with mental illness have higher rates of food insecurity. I've just mentioned 2, but there's lots of them. One is a higher prevalence of unemployment seen in this population group, and then also wage disparities for the same level of employment. Then when we look at women, in South Africa, women at risk of food are at risk of food insecurity for various reasons. So some reasons that have been cited in the literature include higher levels of unemployment, lower levels of tertiary education, and also greater childcare and household responsibilities, which impact on their ability to work and earn a living. There was also a study that showed that female-headed households in South Africa were actually reported to be poorer and more household insecure than those headed by males. There are a few studies in high-income countries that look at food insecurity in women, particularly those who are postpartum and have depressive symptoms. But the literature in low to middle income countries is actually quite limited, which was the basis or one of the main reasons why we thought that this study would be important. So my study aimed to determine the prevalence of food insecurity and its association with socio-demographic factors, with clinical factors and quality of life in women with mental illnesses attending a psychiatric hospital in KwaZulu-Natal. This was a quantitative cross-sectional survey that was conducted at King Dinizulu Hospital. King Dinizulu Hospital is a specialized psychiatric hospital that's located in Springfield in Durban in South Africa. And it's a low to middle income area with a predominantly Indian population. So the instruments that we used in our study was a demographic questionnaire that was designed specifically for the study. We used the Household Food Insecurity Access Scale and the WHO Quality of Life Break Scale. We did receive ethics approval from our ethics board. Then some results from our study. We enrolled 123 participants with a mean age of 50.4 years. Majority of our participants were of Indian race, which was expected given the area that King Dinizulu is based. Majority were single, majority also were living with their parents, siblings, or spouse. Most of our participants had no tertiary education. 83.7% were unemployed, and close to 70% were social grants recipients, and this could have been a pension grant or a disability grant. When we looked at the household food insecurity access categories, we found that 13% of our participants reported to be mildly food insecure, 21% reported that they were moderately food insecure, and 12% reported severe food insecurity. Then when we put together the insecure group, we found that from our whole participants, 47.15% were actually insecure. We also found that food insecurity in our population, or our study population, was associated with a younger age, having no monthly income, having a poorer quality of life, and having a comorbid psychiatric diagnosis. So in our study, we found that almost 1 in 2 women with mental illnesses were reporting food insecurity. So food insecurity prevalence studies were actually focusing on our chosen population. So this is women with mental illnesses, were actually quite difficult to find both globally and in low to middle income countries, including South Africa. And this made finding appropriate comparative food insecurity prevalence rate data a particular challenge. However, we were able to find 2 recent meta-analyses that reported similar food insecurity prevalence rates to ours. So one was Teasdale et al. In 2023, who found a combined prevalence estimate of food insecurity and severe mental illness to be 40% in their population, and Smith et al., which found a combined prevalence estimate of food insecurity and severe mental illness to be 41%. So, of course, unfortunately, the prevalence rates in these 2 meta-analyses are not directly comparable to the prevalence in our study for various reasons. For one, they use different measuring tools. They also did not stratify results by gender, and most of the studies that they included in their meta-analyses came from high-income countries. However, they do assist in demonstrating that the prevalence of food insecurity in persons living with mental illnesses is actually quite high, even though in our particular study, we had expected to find a food insecurity prevalence rate that is significantly higher than that of studies in high-income countries. The scarcity of prevalence studies in females with mental illnesses is a concern, obviously, for us, and one of the main reasons why we think that there's a place for this study. The prevalence rates of food insecurity in our study is almost double that reported in the general population in South Africa, which, as I mentioned before, ranges between 26 and 29%. And again, these reports don't actually stratify food insecurity rates by prevalence by gender. The higher prevalence in our study may actually be an appropriate reflection of food insecurity in females with mental illnesses, given the existing literature that places women and places persons with mental illnesses as vulnerable to higher rates of food insecurity. Then almost 70% of our participants were recipients of social or disability grants, and despite this, close to 50% still reported food insecurity. And this is in line with suggestions that social grants alone may not be enough to alleviate or improve food insecurity. The association between food insecurity and mental illness and quality of life is well established in the literature, and it suggests that, and in our findings, we found similar findings. We found that women who were food insecure had poorer quality of life, or reported poorer quality of life. So other findings, our finding of a significant association between comorbid diagnoses, psych diagnoses, and food insecurity is in keeping with other studies which found that severe mental illnesses are generally chronic in nature, and that chronic conditions are associated with higher odds of having food insecurity. We also, as much as we thought we would, were not able to demonstrate an association between race, ethnicity, and food insecurity, and this differs from the literature, which does make mention of ethnic or racial differences in food insecurity, with Black ethnic groups being shown to be more vulnerable to food insecurity. This lack of association could be for various reasons, such as the historical legacy of the racial residential delineations by ethnic groups, which largely still exists in the area area, in our hospital's catchment area. And then also the number of participants in our study was perhaps too small to detect these differences in ethnic groups. And then some limitations. Our study was conducted in one hospital, so the results are not going to be easy to generalize. I mentioned sample size, so this small sample size decreased our statistical power and then may have contributed to some of our negative findings. We also had no data on total household income, and maybe making some comparisons between total household income and food insecurity would have been interesting. And then just to conclude, we know that access to food is a basic human right, and we know that persons with mental illnesses and women are particularly more vulnerable. There is a need from our findings to screen women with mental illnesses for food insecurity. And the hope is that there would be, in the future, more longitudinal studies and perhaps more studies in other areas that are needed to just look at the extent of food insecurity in women with mental illnesses on a broader scale. And perhaps that can help with later on informing policy changes, lobbying for support, as well as inform interventions that can be directed at this vulnerable group. Thank you.
Thank you. Thank you.